Good afternoon, everyone, and welcome to the February 2018 edition of the Community Paramedicine Insights Forum, brought to you by the National Association of State EMS Officials, the National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research in EMS. Kevin McGinnis is on an airplane today and can't be with us. I'm Gary Wingrove. I'll be moderating for today. Today's show explores the use of hospital-based electronic health record systems with community paramedic services. We'll look at two systems, one in South Carolina and one in Minnesota. They both use Epic, a widely used electronic health record platform in clinic and hospital settings. We're pleased to have Roger Dodds of the Greenville County EMS and Greenville Health System Program, and Pete Carlson and Dave Johnson of North Memorial Hospital in Minnesota. And Roger's going to get us started off with his Epic experience in South Carolina. Roger, take it away.
Okay, Gary, thank you very much. As Gary said, I'm Roger Hudson Dobson. For the last 3 years, I've been working to develop our community paramedicine program here in Greenville County, South Carolina. Before I talk about our actual Epic implementation, I would like just a few minutes to spend to tell you who we are. If you're not familiar, Greenville County, South Carolina is in the upstate region of South Carolina. We're located along the Interstate 85 corridor between Atlanta, Georgia, and Charlotte, North Carolina. Greenville County is approximately 795 square miles. We are taller than we are wide. It consists of urban, suburban, and rural areas. The northern part of the county is in the foothills of the Blue Ridge Mountains, and to the south is flatter areas that is more conducive for farmland. 6 municipalities, of which the city of Greenville serves as a county seat and is in the center of the county. We are the most populous county in South Carolina, which is approximately 451,000 residents. The county's growth rate is approximately 2.1% annually. Greenville County EMS was chartered in 1976. We are a high-performance system that is the sole EMS provider in Greenville County. We have approximately 280 full-time, part-time employees, with 200 of them being full-time dispatchers, EMT, and paramedics. We are a progressive system with a very active primary and assistant medical director. A little bit about community paramedicine in South Carolina. Greenville County added in one thing in addition to the approved curriculum. We just require 2 years experience as a paramedic. The state has approved curriculum, and it says a minimum of 100 didactic hours, 125 minimal clinical hours, and then 24 hours of continuing education annually. There are 4 programs currently in the state. That is statewide. Next month, we anticipate that the state will fully endorse community paramedicine at our state conference. At that point, the existing programs will come out of what the state refers to as a pilot program and allow other systems, EMS systems, to develop their own programs. Community paramedics that have met minimum standards and passed the national exam will have a statewide endorsement on their paramedic certification. This allows them to be recognized statewide as community paramedics. All right, our community paramedic program. The initial planning started out of some grants that were in place to address overall high utilization of underfunded patients. And the planning part started in 2013 and assessing what a community paramedic program would look like. The decision was made at that point to pair up a paramedic with a case manager, social worker, and in the last quarter of 2014, myself and the social worker was in place to was placed to develop what would eventually become the Community Paramedic program. Since the state did not recognize any other community paramedic programs besides the initial original pilot program, we were just referred to as a care team. We had to kind of stay away from the community paramedic moniker until they approved additional pilots. In 2016, we were granted a pilot from the state for our paramedic program, community paramedic program, and I began my initial training through Hennepin Tech in Minnesota. Grant funding was in place to provide for the hiring of 2 additional paramedics, and they started training at a later date at a local community paramedicine program that was developed under the pre-hospital education department at the University of South Carolina School of Medicine here in Greenville. Okay, our collaboration, like a lot of programs between the main health system, Greenville County and Greenville County EMS, there are 2 hospital systems in town, Greenville Health System, and then Bon Secours St. Francis Health System is the other health system in town. Our program focused on hypertension, diabetes, respiratory diseases, and congestive heart failure. For grant purposes, we focused on the uninsured, which had been identified as high utilizers. And since we were a state that was a Medicaid non-expansion state, Medicaid chose to develop a program called the Healthy Outcomes Plan. That helped address the uninsured that did not meet, they were kind of in the donut hole. They did not meet the requirements for Medicaid, but did not have funding for private health insurance. That was where we originally obtained our list of patients from, and we focused on the 5 medical neighborhoods that the hospital system had developed, which were identified as the underserved neighborhoods in our western corridor. We also set up a referral pathway for our EMS providers to be able to get patients that they identified as in need of community paramedicine over to us also. Our early days in documentation was in our EMS EMR. At that time, we were using EMS charts. I was the only one actually documenting there. The social worker that I was with was documenting in the hospital EHR. At the time, the EHR, there were actually several. There was one in the emergency room. There was a separate system for inpatient, and the primary care offices also used a different one, which is why the hospital system chose to go with a system that could provide kind of one-stop shop, which they ended up choosing Epic. The difficulties that we found while we were kind of all charting in different areas were it was just very difficult to trend data across patient encounters. Everybody realizes that the EMS records in general is very isolated to that one visit or that one encounter. You really don't see what happened prior to any other visits that another provider had like you would in a hospital EHR. The other thing that we found difficult was actually communicating with providers. We deal with a great deal of patients that go to the resident medical clinics here, the internal medicine clinic and Center for Family Medicine. Those residents are kind of in and out all the time, and they really depend on the health record to understand what's going on with their patients, especially when they're not actually in the practice that day. So we started looking at what life would be like if we were all on one electronic record, just like the hospital had experienced having different EHRs. We were looking at what it would be like for us to also be up under Epic to be able to communicate and document. The health system, Epic, was well underway at this point. And in the last quarter of 2015, it was implemented in the ambulatory care practices system-wide. And then in the first quarter of 2016, Epic was implemented in all inpatient settings system-wide. At that point, I was granted read-only access. I found that invaluable because I could actually see what was going on with my patients. But it still did not allow me to communicate with the in-house providers and to document treatment notes and plans so that the providers were able to include that with their care and kind of know what was going on inside the patient's home. So after the inclusion of the 2 additional community paramedics, it was more and more evident that we were being hindered in our patient care by not being able to communicate our care as part of the Epic patient care team. We reached out to the Epic team to see what it would take to allow us the ability to document in Epic. After review of both the inpatient and ambulatory care systems, it was decided that we should go forward and be set up much like an ambulatory care practice. That would allow us the ability to schedule an encounter with a patient and then document in a treatment note. This would show up, of course, in the encounters, just like any other primary care provider or inpatient encounter, and could be reviewed by others. Then finally, after a year of talking and working with the Epic team to build out our Epic system, now keep in mind that Epic was still fairly new to the health system. They were still turning up other practices, other hospitals that the Greenville Health System owned and had developed a relationship with. So it may have taken us a little longer than what other people's experiences with Epic and building out a side of Epic for us. So we just kind of look at, I don't know what the standard or the norm is, but it took us a year really to get up and operational on Epic. Since we were Anomaly, if you know anything about Epic, Epic is very good at wanting to bill for something that you do. Everything you select, every box that's checked may have a billing associated with it. So it wants to drop a bill to that patient. So we really had to focus on, when we were building out Epic, how do we stop that billing process since we were a non-billing practice. There were several stops put in place, and then at the end of the day, on the billing side, it would just scrub those charges if it actually made it through the system. So at the end of the day, once we signed the encounter and closed it, the billing system would actually scrub any charges associated with that with our practice. We also worked through orders and procedures. We're having to integrate and educate the Epic team. So these are experts in their field, labs, nurses, physicians, on what is a paramedic, what is a community paramedic, how do we document. We use standing orders sometimes. That's kind of a no-no inside the hospital practice. They don't really like standing orders, but how do we document all of that? Working with the lab folks so that we can collect labs and then put them actually into the system that it was collected, and then also scheduling patients, which is not only scheduling, but you have to walk through the billing process. Keep in mind that our Epic build was a generic build. It wasn't built specifically for us. We are kind of in the point now where we're looking to the future to go back and really tweak our build to make it more of our own, which we understand that is a doable thing within Epic. In December of last year, so only a few months ago, we went live in Epic. We didn't really have that many bumps. There's only 3 of us, so it's not like a great big practice where you've got lots of providers and run into a lot of issues. We were all used to documenting the same way. We were using Epic in the same way. So we found really very, very little things that kind of were stumbling blocks in the first couple of days and first weeks that we worked through the system. And unlike really on the EMS side, we were approaching things as primary care, so there was nothing that if we could not document it, it wasn't the end of the day that we couldn't document that, whatever it was, and until Epic could really look at and figure out. Some of the things, since the health system is rather large, they want to keep down on the specifics of like encounter types and just a lot of the things in the drop-downs. They're wanting to keep those down to a minimum. What we were originally using, we found that that was creating some issues, so they ended up putting us in as a nurse visit, which also causes some issues because you see a nurse visit, but yet it's a community paramedic. So which is it? Is it a nurse or are you a community paramedic? So that's one of the first areas that we're going back to identify, or that we've identified and we're going to address, is actually putting in a new visit type specifically for community paramedics, so that there's no confusion that no, we are not nurses, we're community paramedics, and because we have a very specific scope of practice, we don't want that confusion to be in the system. Other things that we kind of encountered that was a problem we worked through, when we collect labs, it wants to print labels. Basically what we found is that we just still print labels. They just go to nowheres, and we're still able to document that we did collect those labs. And then once we bring the sample by the lab, they just reprint the labels, and we initial them once they're put on the tubes themselves. What we have found with our Epic Live system is that we've really improved our communications with the providers. Prior to going live with Epic, if any of our patients bounced into the emergency department and inevitably got admitted to the hospital, the emergency care folks did not see what was going on in the home. Our patients are sometimes poor historians. They're not able to communicate well. Their medicines, they have a lot of polypharmacies. They visit both health systems. So there really was no way to pull all of that together until we actually went live in Epic, and we're actually painting that complete, not only medical side, but also the social side of what's going on in the household. So our encounters show up just like any other encounter. So inpatient case management, they can see that the community paramedic program is involved with this patient. They can review some of the documentation. They can reach out to us if there's DME, the durable medical equipment issues are going on, or that they've ordered things. So the messaging side of Epic has really helped speed that process up. Also messaging the primary care providers about refill requests. If we're able to see labs, if there are panic values, then we can really be prepared for some additional orders, or either we may need to, if they've got a high potassium level, then it's just going to be an ED visit. So we can really proactively work not only with our patient population, but also communicate those things better and quicker, so that we can cut down on a lot of the unnecessary ED and inpatient visits. Our CHF patients, it's easier for the CHF clinic to see weights. We're now getting standing orders actually put into Epic to say, if this patient gains 5 pounds, put them on an additional dose of Lasix, and they put that in place for us already. We're able to see the after-visit summaries from an inpatient visit. The medication adherence is very important to us in our program, so we're able to reconcile the MAR. Also works really great for patients that are that have lots of different pharmacies to make sure that that list is updated and accurate. But our most important thing is actually being able to have our encounters show up to the primary care provider, the ED and inpatient folks. So what does Epic have in the future for us, or hold in the future for us? So you heard me mention that our EMS EHR was EMS charts in January of this year. We actually went live with ESO. We changed vendors after many, many years. So we're looking forward to capitalizing off of our new software provider. More importantly is the bidirectional health data exchange. They are currently working getting that up and operational with Epic. My understanding is it's supposed to be done by the end of next month. I haven't heard that actually carved in stone, or there's not been a date announced, but that bidirectional data exchange is actually supposed to be in place. I hope that actually will end up help us get data to the state. None of our data currently or previously was being reported electronically, as is the requirement for the 911 data to be, or actually all pre-hospital patient care reports has to be submitted electronically to the state. The exception to that is the community paramedic programs. Since our patient load is a little bit lighter, we are actually submitting a summary every quarter to the state just to give an overview of what we're currently doing. They are in the process, they being the state, the Bureau of EMS, changing the database to start accepting the community paramedic data electronically. So we're hoping that with the health data exchange between Epic and in turn our department in Epic, my vision is to use that health data exchange to send the data over to ESO and then ESO on to the state. We're also using Epic and its ability to capture our data to work on funding and sustainability of our program. We're probably no different than any other community paramedicine program out there that we're looking for a funding source. Our grant actually ends later on this year. The county has agreed to pick up our 3 FTEs, so we're not at peril of losing our jobs, thank goodness. But there would be the hospital system and EMS would like to see some reimbursements come through. So we're hoping to capitalize off of the data that we're actually collecting in Epic. And one of the ways that we're capitalizing off of some of the things that Epic is able to provide is actually using the flow sheets or flow charts that are actually in there. Things like, did we give bus tokens? Did we make an appointment for the patient at primary care? How many blocks, 15-minute increment blocks of time did we spend? Just to make it easier, so if I'm there, I document all of that, I sign it, close it, and then there's a report that generates all the data necessary to explain our existence. And then at the end of the day, we want good patient outcomes. So being able to work with the providers, provide better, quicker, effective treatment plans, we are hoping to show and demonstrate that we are having better patient outcomes, which is only going to help with our funding and sustainability. And with that, I will turn it over to the other guys to talk about their program.
All right, Roger, thank you very much for that. We're going to shift gears now and move to Minnesota. And Peter and David, you can take it away, and then after this session, we'll open the lines for question and answer time.
Well, welcome to Minnesota, and great presentation, Roger. We're looking forward to adding on to that, and let Dave Johnson here introduce the two of us.
Yeah, so I'm Dave Johnson. I'm a community paramedic up here at North Memorial Health, and then Peter Carlson's my manager, is also a community paramedic. Yeah, in the presentation you may see some patient names and things like that. Those come from a training environment, so none of this presentation contains any protected health information. I'm not sure how many of you have 3 hours a day to spend on YouTube like I do, but if you're familiar with the Will It Blend series, it's a wonderful spend of your time. But we're trying to figure out, does Community Paramedic and Epic blend, because we see a lot of different organizations we've interacted with that are either having difficulty getting on board with Epic, don't think it's the right solution for Community Paramedic, or have some other impediment to it, be it whatever your ownership structure happens to be, like if you're not affiliated with a health care organization or whatnot, but we'll talk a little bit more about that later. So obviously neither of us have any disclosures, but we are both remarkably handsome. But we're going to look over kind of what our current state is, what your deployment options might be if you're an organization that's looking at placing your community paramedic service on Epic, and then kind of some strategies and also some challenges that you may encounter when you're looking at deploying community paramedic service onto an Epic platform.
So to launch, we'll give a little current state here at North Memorial Health and give you an idea of who we are. We've got our medical director, Dr. Tangi, in the lower right there, myself as the manager, and then staff along with one of our program's customers there in the top. And the team members that you see here we've evolved to this point. You know, we started off with no dedicated supervision management or really medical direction for a couple of years. But as we've built our business case, we've also built our operating case. And so we're at a great point for the applications that we're using Community Paramedic in today, but we're really, I would say, at capacity as far as volume. Our program has seen just shy of 3,000 referrals in the 5 years that we've existed. We're embedded within a larger healthcare system that has 2 hospitals, about 25 clinics through our ACO that goes up to about 40 clinics. And then also 7 air care bases along with about 120 ground fleet ambulances. All of our work is done in northwest Hennepin County in the Minneapolis area. And the name on this list to pay attention to, there's 2 of them. It would be Dave, my counterpart here who's talking, I think is probably as, if not more important than any one other piece of the puzzle, especially for today's presentation in Epic. We've really leveraged Epic in a lot of different ways. And then our program assistant, Cherry, which we'll cover here in a little bit. So a little background, I think the joke is you have to say yes for quite a while when you're launching your program. Most of the folks on the phone are aware of what that means, but you definitely hit a point where you need to also be comfortable with saying no to applying Community Paramedic. It's a adaptable and versatile tool that can really help in a lot of different areas. Here's where we've landed as far as our service lines and our focus. So you'll see the transitional care management, which is fairly new for us. We've been doing a lot of transitions of care work, but historically we haven't billed out to Medicare for that work, and that's something we've been able to do largely because of Epic. Our North Rising is one of the last grant-funded projects that we're working on, or one of the last projects rather that's grant-funded, and that's a Health Rising Medtronic opportunity, sunsetting in September of 18, but it's been a real good project for us. And then our That's Better, and the rest of them, kind of minus bariatric surgery, fall under our accountable care organization umbrella, in that our institution bears financial risk and opportunity, a reward, if we're able to provide a total cost of care that's less than the threshold. We've also got the pediatric asthma, very focused under our IHP or our Medicaid umbrella. The bariatric surgery follow-up, that's payer blinded, so it's just who our organization provides that intervention to. And then a lot of general program work, and we try and keep that to 10% or less because it can start to overwhelm us. So as far as Epic, and then I'll hand off to Dave on the real detail of of Epic, but we've been using this since 2012. We had a brief period similar to Roger where we were doing some physical paper charting. We have never charted in our emergency EPCR solution, but we'll touch on that in a little bit. And as a fully integrated user, it simply means that we're given the same access to a visit navigator pane and ultimately the same visibility for all other providers in the system. Our staff are able to use their laptops that are assigned to them along with their iPhones to remotely access. So they all have AirCard loaded devices that allow them to be able to actively chart in the home, and that's a big value add. And then they use a mobile Haiku access point for other aspects of their Epic work. So the referrals and what that means in terms of scheduling. There's been a few renditions of this. This is, I would say, the most recent. Excuse me. We block out our schedule in 1-hour chunks. We did 2-hour blocks for the first couple of years, shifted back to 1.5 hours, and now we're down to 1-hour blocks. So, per FTE, you can do the math of what we're trying to get to as far as efficiency. And I would say we have the upper hand in terms of geographic coverage. We can see a denser population in a smaller area. So whether it's a primary care provider, a care coordinator, a hospitalist, a social worker, which Roger really hit the head on that one in terms of, this inpatient to outpatient or the continuum of care is a big deal for us to be able to work with our care management folks. So all of their referrals end up coming in the same. They get dropped into a work queue. I keep an eye on it along with our program assistant just so that, she can obviously be away for a period of time. But the work queue allows us to track and monitor our outreach to the various patients and customers and be able to make sure that we're closing the loops on that and messaging back to the providers our rate of success as far as getting a hold of the individual. So this is Cherry, and she's that second name on the list that, I think if you're going to start a program, it could be seen as I guess, fluff or not necessary to have a scheduling assistant. I would say that if you have a strong program assistant and a strong Epic builder, someone who's really familiar with Epic, you're off to a great start. They essentially are doing a lot of the managing workflow, policy, protocol build out without even necessarily realizing that's what's happening. So Cherry handles all of our referrals, outreach, and builds out the appointments. The background to this just gives you a visual as far as the notes that can go in, current status of that chart, the provider, which all of our community paramedics are listed in their own zone geographically, and then is able to do all the rescheduling requests from our staff via InBasket, which is like an internal email basically for Epic, which we'll also touch on a little later. And Cherry is also able to validate insurance coverage, which is helpful. We approach our billing a little bit differently than Roger that we heard earlier about, which we'll touch on.
So our clinical documentation that our community paramedics use, we have built standard templates for all of our community paramedics to use on each individual service line. They've taken a number of different looks over the course of the past couple of years, but we've really narrowed it down. We moved from having each community paramedic having their own kind of custom templates that they articulate to the way that they like to do their charting, and now we've moved more towards standardized documentation, which has helped improve some of our efficiency and also our ability to pull data. But again, it's specific to the service line. Right there, you just kind of see the template that I have for just kind of a generic program intake note. But total, I think we have about 38 standard program notes. We have an intake note, a follow-up note for each specific service line, and then there's some insertable modules that we're using. But our clinical documentation lives at the same level again as any provider, pharmacist, anybody, and it has the same visibility, which we think has been an absolute imperative to us having success in this realm and being really fully embraced by our the entire ambulatory portion of our organization. The other thing, again, since all of our community paramedics have internet-connected laptops. They do their charting at the customer side. It allows them the ability to, hey, let's look at your A1Cs over the past 3 years and let's see what you've been doing with your A1C, and let's look at it in a graph, and kind of adapting how we work with our customer to their specific learning style, which works pretty well, and also makes it, I have no idea where I was going with that, so we'll just keep on moving. Actually, the other thing on here, since we have a lot of different program lines, we've started putting in specific instructions so that the community paramedic doesn't have to remember all the nuance of a specific service line, especially if it's something that they don't do super frequently, such as our bariatric program, since we're only doing a handful of those a month. We've put in some instructions that the community paramedic can essentially just hit the F2 key and tab to the next set of instructions, and it gives them explicit instructions for what they need to accomplish at this step. The notes are also designed in a way that kind of logically flow or follow the traditional evolution of a customer encounter. For interaction with PCPs and teams, we CC all of our charts to their primary care provider and any other pertinent providers that are important to their care. We may be seeing somebody on behalf of another one of our community paramedics that wasn't able to see that customer today, so we may CC them. All of our community paramedics also add themselves to the care team, which also helps with our visibility and also pushes for our integration, but it does go directly to their provider versus some of you may be familiar with MyChart. So we, with MyChart, it oftentimes goes to like the medical assistant in the clinic. This goes direct to the provider, which helps with the communication. And we also want to make sure that all of our customers are using the portals as they're available. So for Epic, the specific product they have is MyChart, which is available both as on a web platform and then also on a mobile platform. We want to make sure that we give the customer as much ownership of their chart as possible and make it a little bit easier for them to make appointments, to look at their lab results, to interact with their provider, and to reduce some of the barriers that have kind of made traditional healthcare really difficult to consume in the past. So we see that MyChart's a really strong resource for that, and actually one of our strongest segments of users of MyChart are a population over 65, which is kind of contrary to what you would think. But it turns out there's a lot of people with smartphones and computers out there.
So touching on revenue, which has also evolved over time, what you're seeing here is current ability to bill is this CPT T1016, and all that means is it's a 15-minute monitor increment with a modifier of U3, and so all of that really just stands for a care management code that Minnesota Medicaid DHS, Department of Health and Human Services, set up for us so that we can request payment. And that includes the ability to capture revenue for any Medicaid life that's under these managed care umbrellas. And so we're building out, obviously trying to cover cost and ultimately tie ourselves to the impact in getting the organization across the threshold and into savings territory. So we also run a quarterly report, and that's where, for us, it got a little confusing. Optum, as its own electronic data warehouse, works with Epic as its own electronic data warehouse. And so our company uses both Optum and Epic to ultimately review interventions while monitoring claim requests. And so fortunately for us, we can actually look at claims from all different organizations in the state and even in the country with a 90-day delay. And so while we're billing out, and within Epic, and for today's sake and purpose, I would say the lesson learned here is your professional billing is able to actually push out charges for you. The second CPT, or procedural code, that we're using, that's set 99495 and 496, are a married pair in the transitional care management work we're doing. So one of them is a high complex and one is a moderate complex. And what that boils down to for us operationally is we need to see that individual within 7 days of discharge from hospital to build a high complex, or 14 days to build a moderate complex. You also have to call the individual within 48 hours of discharge, and then they have to stay out of all institutions for 30 days in order to be deemed successful. So my guess is a lot of folks haven't gotten into this space because it really takes hitting your head against the wall quite a few times while working with the revenue cycle at your local organization. But ultimately, yeah, it's been a big saving grace, I think, for us, because we really need to to show our worth while the majority of healthcare remains this fee-for-service, volume-driven beast. So we're billing through, and that's a typo, we're actually just billing through professional billing, not to be confused with hospital, and are having moderate success as far as capturing, 28 to 35% capture, which isn't, it's a difficult industry standard to really compare to. There's not a lot of community paramedic programs to chalk up against, but as an organization goes as a whole, we're doing all right, and it just takes a lot of conversation and communication to your contract managers at the various healthcare plans. So the medic themselves actually drop the charge, and for the top portion, it just goes straight to coding and is released. For the bottom portion, that has fallen under my purview, and so I monitor what's called a T plus 30 or a today plus 30. So each time the paramedic or our physician does an in-home face-to-face visit, we're looking to bill 30 days after that individual was discharged from the hospital. So it definitely takes some more work, but we're building that in such a way that it'll be fully automated before long. So I'll start and then hand over to Dave on reporting and metrics. Epic itself has got a lot of opportunity. What you see there in the 1.819 million, it's just number of unique MRNs in our Epic system. We're obviously slicing down to a small portion of that, those that we've intervened in. A lot of our data that we capture is pre-post spend, as we've seen with a lot of different programs. But then we're trying to find the correlators to what got us to that pre and post reduction spend, ideally. Often there's other common interventions that are paired with ours. Medication therapy management pharmacist is one, care coordination is another, and then patients having access to community-based resources tends to be another one. So we can report through Clarity, our BOE, our benchmark, our slicer, dicer, which is a really handy way. And for those of you on the phone, if you have access to Epic, that's probably the one thing to write down from our whole presentation, slicer, dicer. Odds are that you have it as an add-on, but hasn't probably been broadcasted. And then the provider efficiency profile, which I think for all of EMS, this is a big point of pride, because not only are we listed as a provider within Epic, but we can monitor that efficiency of our staff, the proficiency and efficiency, and as a manager, you can really keep an eye on work-life balance when folks are documenting, how efficiently they're documenting, whether or not they're copying and pasting a lot, and you can find pain points that usually lead to really good lessons learned and discussions with your staff.
And I think the provider efficiency profiles also help validate whether changes you've made on the back end, for like templating or other things, are actually causing an improvement in both the ability to complete your clinical documentation in a timely manner, as well as the work-life balance and also the provider experience. Because ultimately, for those of you who have been involved in this, CP can get a little bit can become a little bit of a grind, and anything we can do to make our other community paramedics' lives a little bit easier and also make the quality of our documentation look like we would expect it, we want to do that. And I think Slicer, Dicer, and PEP really allow you to do that. So there's a number of, we end up, Pete gets a lot of emails on, hey, we're starting a new program, what should we be doing for documentation, this, that, and the other thing, by virtue of just the good work we've been able to do. And also, I think Gary just CCs every email to Pete. But there's a lot of different implementation options when you're looking at something like Epic, and which route you choose to go. I mean, for CP, there's obviously the isolation option where we live in the EMS ePCR system. And some offer interoperability with Epic versus through a healthcare information exchange, But generally, your EMS EPCRs are limited to the scans file of the chart review in Epic because it gets faxed just like any other 911 chart, and gets scanned in and then I think rescanned in about 14 other times until you have this lovely product, which is what they end up looking like for the people who are actually looking at your clinical documentation. It's really limited in your ability to collect data. You have to do really a lot of manual tabulation, and that's time consuming when you're trying to figure out what the outcomes of your community paramedic program are. There's also read-only access, as the folks from the East Coast were talking about earlier. So our option that we have is Epic CareLink, which is a internet site that you can log into. It allows the ability to view shared patients, and there are some adjustable permissions. They're actually a little bit more broad than just the in-basket messaging and orders entry, but that's what we previously used it for in a prior manifestation of what we were using it for.
And a good use case for Epic CareLink, as you build out your program, if you're anything like us, you end up really struggling to graduate patients off of your group. In other words, you may target, for whatever reason, operational efficiency. You want to do 5 visits per person, and if you're anything like us, pretty soon you're going to 5 funerals in 6 months because you stayed with these people kind of through the end, literally, and at times there's a dependency that's created. And I would say that it's often the lack of external resources, but as our program has built more of those external partnerships and resources, Epic CareLink can be a good access point for your community affiliates to be able to see lists of people that you've built out. So if it's a mental health clubhouse, for instance, which is a partner of ours, they're able to see into the EHR for their first time ever and offer a better experience. Or if it's an external community health worker, or group of community health workers, you're able to grant them access as well. So it is pretty neat to be able to adjust those permissions to what you need them to be to decrease some of the dependency on your limited staff.
So partial access was the route that we had, and I think most programs have to deal with having partial access as they first build out a program because your Epic analysts or builders may not really even understand what community paramedic's about. They don't understand what we need, and it's just a nice, easy kind of, you go sit off in the corner, we'll just do this to pacify you for a little bit. It's a quick build. It doesn't require a lot of analyst time, and it's often used as simple templates, so like a telephone encounter or a care coordination encounter. It's a simple encounter. Again, quick to deploy, but it has limited visibility, and really your ability to capture any revenue through it is very limited. It's a good stopgap until you can get all the way on, but ultimately we feel that full implementation within Epic is really the only acceptable solution if you really want your community paramedic program to fly. So in our world of full implementation, the providers will enter the referral to community paramedic in Epic already, just like they would enter in a referral to a dietitian or a basic metabolic panel or any other thing. They get entered the same way, pops into our referral work queue. As we've already talked about, our documentation lives in the system, health record. Our staff all have access to the mobile platforms. So like for a telephone, it's the Haiku product, and then if you have a tablet, you would use the Canto product. And then if you're really motivated, you can even hook your Apple Watch up to it. Then again, we accomplish our revenue capture through Epic, and then there's also really good opportunities for measurement and reporting within full implementation that are not available if you go with a partial build out. And then the final option that exists, and I'm not sure if any community paramedic programs have tried falling under this, but there is Epic Care Home Health and Hospice, which is a custom module within Epic. It allows for offline access, but it lives in Narnia. If you've ever tried to, if your organization has home health as part of it, and you've ever tried to find a home health chart, it's near impossible to find and to get some meaningful, good information out of it. So it's really focused on the objectives and reimbursement needs of a skilled nursing home health agency or else a hospice agency. It's not a route we've chosen to go down. We're very happy with the solution we have. It's just you have to have the internet connection, and there's some added expense with that. So moving into some strategies and challenges, and it's not the most well-organized next 3 slides, but I've done better. I think remembering when you're coming into this that you're probably a really small piece of a big system. North Memorial Health has 10 community paramedic staff members, and how many people do we have
about
here?
5,000 FTEs, so moderate size.
Yeah. And, you look at a system that's much larger than ours, such as many of our neighbors like Line of Health or Healthy or Fairview, and, you can triple that or quadruple that. So you're a really small piece. So when you're asking for IT development time, make sure you have a really specific ask. Talk to the other people who have done it, and see what other people have needed, or have been able to use. So if your organization already has Epic, take a cruise through UserWeb. It's a wonderful, wonderful resource to figure out what templates other organizations are using, but really have a very structured ask when you're talking to IT. And again, when you're doing your initial build and you have some dedicated time, that's the time to come with a really organized list. Say, hey, North Memorial Health is doing this with their Epic. We would like to do this also. Or, or Greenville County is doing this. Yeah.
And my addition to that would be emphasizing the physician champion, and that should really take place in the provider physician pool. So if you're going down, a congestive heart failure path, really find your physician who's the lead and most connected to your chief medical information team. And then also the user web would be the second thing really worth writing down from my perspective. And Dave would have a lot more to add to that list, I'm sure. But if you look into Slicer Dicer and then look into user web, which is another website, and within there you can go to what's called the community library, and you can take as many smart phrases as you wish, and that way you're contextualizing your ask to your IT builders by saying, here are the type of notes that we're looking for, and save yourself and them a lot of work and time.
Because if you cite a specific URL, they can actually just download that directly from UserWeb and import it into your Epic software.
And then the lingo portion, we worked for quite a while under smart phrases to learn that a lot of the data is not mineable, even if it's in a drop-down. But if you move into smart forms, which those really take a lot of kind of time, and you go through a governance structure to normally get approved, and then there's an associated cost. So some of those builds can range from $200 to $60,000. And so just knowing where your shared services are, again, kind of the begging, borrowing, and stealing is a great opportunity to reduce some of those costs. Some of the challenges, you saw a slide earlier with the gentleman's back to you, who's actually in the room, so I feel comfortable pointing this out. He's been in EMS for 44 years, and I think that technology is perceived and utilized differently by everyone. And he's a great example where initially we were writing paper charts still in our 911 side of our job, and so we were introduced to electronic charting at about the same time, within a matter of months, to when we were introduced to Epic. And I think the learning curve is significantly different between the two systems. And so I would advise, referencing John in this case and his ability to really not only catch up but surpass his abilities when it came to handling a robust, large, data-saturated tool that at times can feel like that mega mall when all you're doing is going in to buy a pair of socks. You got to find your way around, and everybody's really caught up to speed, which is a really rewarding thing to watch. And that's really secondary to the work that Dave has done as far as building out standardized templates, so that rather than showing up on a 911 call and having the same kind of blank chart every time, you're showing up on a call for a specific care plan for a specific person, and really given the data fields that you need to complete in order to stay on track. So that standardization is really key. The business agreement portion, and I'm really excited to hear from Roger if they're able to get a bi-directional exchange between ESO and Epic by the end of next month. I feel like we've been in that conversation a number of times with various vendors, and so it's interesting to watch us all seek that same solution, and hopefully we get a unified voice, which I think we are more and more. But we have had the honor twice now of going out to Epic's big user guide meeting, or UGM, and presenting, and talk about a small fish in a big pond. It's really intimidating to try and get them to exchange information with really anybody. The next bullet, we're hoping that an EMS solution eventually comes on the horizon, or that, again, it's easier to exchange, push and pull bidirectionally, so that EMS can come out of kind of the archived media scan tab and into the active chart review. I think a question to ask yourself is who will do the department Epic development, finding someone within the group that has an interest in that, and even funding them to go to Verona. And this whole presentation can be replaced with, Cerner, eScripts, you name your EHR that you're facing, and just substitute that in for Epic every time we've said something, because all the EPCR solutions, Athena, everybody's moving towards having these capabilities. But just having someone on the team that's already interested in it is going to be a big value add.
And then as we look for the future, how we're going to make Epic work better for our clinicians, we see a number of different opportunities. There's some additional modules that we're hoping to integrate. We have not integrated the medication administration record yet into our practice, but there's a new case management module that should be coming out here very shortly, and is really promising for a lot of our kind of high-level case management stuff that we're looking to accomplish. There's so much that Epic has to offer, and being able to distill it into what we actually need versus what's noise is hard, and I think that's where it's good to have a really close relationship with your IT department, and if you have a business relationship manager, those are really, really crucial relationships to not only get in the first place, but also maintain. We're also hoping in the next couple weeks, we're looking to begin trialing Dragon voice dictation to see if that offers us a lot of opportunities to improve our efficiency and proficiency within Epic. This summer, we hope to be regularly pushing care plans back to our traditional paramedic clinicians for our most expensive ACO lives as well, so that we can bring some intelligence out of Epic and push it to the traditional paramedics in a way that is consumable for them, and also allows us to do really our best due diligence for the customer, and even get down the world of alternative destinations, which we have not been able to, we have not gotten down yet. And then also, we're just looking for other ways that we can help enhance the work-life balance. You see the graph you see on the bottom is actually a screen grab from our PEP reporting, and it's just trying to look at how much time, it tells you how much time community paramedics are spending in Epic on days that they're not scheduled, which really plays into work-life balance. You look at any provider, and where are their frustrations with an electronic health record? Well, it's the fact that they're charting every night until 8 o'clock, and that's unacceptable, and our organization luckily has placed a really strong emphasis on work-life balance, which is much appreciated.
So the bullet 3, I think, is really applicable to those on the line as far as the care plan push. And what we're hoping to do here is just change trajectory, as Dave noted, of some of our customers that are calling 911 more often than others. And so what we've heard from our EMS partners is that, they really are kind of starting from scratch. And so there's 2 software components that are needed for that to go smoothly, and that's a robust CAD, or a computer-aided dispatch, that has a memory that you're able to, use some unique identifier so that you can catch that further upstream and be able to divert some of those calls. And so our hope is that we end 2018 with having community paramedics co-responding to a fair number of 911 calls. And then when we're unable to, whether that's time of day or, because keep in mind, you typically get a pretty senior staff interest in this role, which has a fairly low appetite for working in the midnight to 6 shift, which is another problem that we're looking to address this year. But you're able to divert some of those patients from the ED over to primary care clinics, urgency centers, and then ultimately keep them home longer and be able to intervene. So I think that's really our big motivation, to have those snapshot care plans loaded initially as a PDF, long-term, hopefully as a constantly refreshing data source for anyone who's calling 911 within our PSA.
So I think in conclusion, really here at North Memorial Health, our verdict on does community paramedic and Epic mix is, yeah, it's absolutely imperative to our success. I don't think that our program, or really any other program that's fully implemented, would have been able to appreciate the success they're seeing without full implementation.
Yep, and so we found that it does blend, and we feel that a program will do, I think, great no matter what EHR or what charting system it attaches itself to. The core work remains the same. We've just had a lot of luck with Epic. There was a recent Minneapolis Business Insider magazine that got floated around through a couple social media outlets that had a large system CEO stating that his feeling was that Epic was an impediment to innovation, and requesting us all to go march in Madison. And I thought that was pretty interesting, because while there are aspects and components of Epic that feel very, very revenue cycle driven, we've really had a lot of luck in getting in and using it in a creative way, and have found each of its annual updates to offer even more towards the consumer-facing pieces of it. So we hope that anyone who explores it has similar fortune as far as the stars aligning and being able to get off the ground, and any other solution will do you just fine. So appreciate the time, and we'll open it up to any questions or discussion.
All right, Luke, don't open the line just yet, but get ready. I want to bring us back to one slide. The billing codes that North Memorial referenced, the first one there is a Minnesota Medicaid-specific code. And if your state is paying for community paramedic under Medicaid, it's not likely they're using the same code. So I just wanted to point out that that's probably not generally usable by anybody outside of Minnesota. The other two codes are transition of care codes, and may be usable by anyone in the country. That would be something to talk to your billing people about. But that top one is likely not usable anywhere except in Minnesota. Okay, Luke, if you want to unmute the lines, we'll do question and answer time.
The conference has been unmuted.
Anyone have a question or comment for our presenters? Quiet group today. No questions or comments?
It's Jason Scheiderer here.
Go ahead, Jason.
So for the guys from North Memorial, are you referring to the Healthy Planet module as the new care management, or something different for like Epic 18?
Well, yeah, so we've had our analysts out. They just got back last week, actually, for all the Healthy Planet build-outs. We're referring to our November update in the hopes of using Healthy Planet more. We've really underutilized it as a system. Is there any particular part of Healthy Planet that you're curious about?
No, we helped with some of the initial construction. It was still a 2-day course when we went live, but we're upgrading to Epic 17 in March 10th. So I know that was an area, some of our transition of care and some of our research areas were really, in population health, we're really excited about.
Yeah, the features that we've used through there are really largely around dashboards and registries. Do those two concepts resonate?
Yeah, we have a few that we have a few registries that they're trying to bring online, especially with some of the lung and the cancer stuff.
Yeah, the registries have been invaluable for us because it allows us to look at populations through both a payer lens for our ACO, our Medicare shared savings, and our Medicaid integrated health partnerships, but then we're also drilling further down to disease-based tracks and then opening up certain interventions and provider types based on that. So we're really still in an infancy, but having a lot of excitement around registries.
Anyone else? All right. Well, thanks everyone for joining us today, and thanks again to our presenters. It was good to get this session out there. There's a lot of questions on health systems that use Epic, and so I'm glad we were able to do this. We do archive these sessions. All of the previous sessions that we've done are available on the cpif.communityparamedic.org website, and the one from today will be accessible there in the next couple of days. So if you have someone that you know might be interested in reviewing the archive of this session, please go there in a day or two. And thanks again to our speakers. Our next show will be Monday, March 19th at the same time. Kevin hasn't given us a topic yet, but he'll send the notices out the way that he normally does. So thanks again, everyone, and hopefully you'll join us again next month. That's it for today.
Thank you.